we are very honored to host the following panel on healing trauma in our communities. And George Kaplan is going to moderate the discussion, and he's going to bring his decades-long commitment to this area to understanding the health of the individual in the context of their community, relationships and experiences. And on our panel, as we were just hearing of, Christina Bethell is leading researcher on the impacts of childhood trauma, informing clinical practice and policy. Ken Falke is leading an extraordinary integrated model for healing the trauma suffered by combat veterans. And then Andrew Masters has worked to support Baltimore youth and families for over 10 years, both within the schools in Baltimore and now in the Baltimore City Health Department. And before I turn it over to George, last night I was just thinking about this panel coming up, and I was looking at some of the things that Dr. Martin Luther King Jr. represents and what he has said, some of his quotes, and it's a call to compassion, clarity, and courage. And I think in these times, these very difficult times, I think his words are very apropos. You know, compassion in the nonviolent nature of hopeful activism, ally relationships and mindfulness with the marginalized, clarity about the morality of our actions, institutional and personal, courage facing social inequities and embracing the possibilities of a beloved community. And just a couple of his quotes. One is, dare to be known. People fail to get along because they fear each other. They fear each other because they don't know each other. They don't know each other because they have not communicated with each other, is one. Dare to speak. Our lives begin to end the day we become silent about things that matter. Dare to act. Never, never be afraid to do what's right, especially if the well-being of a person or animal is at stake. Society's punishments are small compared to the wounds we inflict on our soul when we look the other way. And then leading into dare to hope. We must accept finite disappointment but never lose infinite hope. There can be no deep disappointment where there is not deep love. And then dare to lead with soul. There comes a time when one must take a position that is neither safe nor politic nor popular, but he must take it because his conscience tells him it is right. So he has a lot to say this.
Dr. King also said, and I'll probably butcher the quote a little bit, but the arc of history bends towards justice. And we are at a point in this country when I think it is not bending towards justice, it's bending in the opposite direction. That's my political speech for the day. I think it's a level of countrywide trauma that will take a long time to recover from. And as somebody who's spent the last 50 years studying inequality, social justice, discrimination, segregation, et cetera, it is very painful to even think about these issues. But they're real, and we need to think about them. And I thought I would, I'm the moderator, I'm not giving a speech, but I thought I would preload the discussion a little bit with a few comments, which are not meant to take anything away from the three presenters we have. Their work is important, and they're doing really great things, and nothing I say takes away from that. But I do want to expand, and maybe I won't be expanding, but I think I may expand the focus a little bit to not only talking about healing in communities, but talking about communities that are hurt, that are traumatized, and how we can both prevent, manage, and deal with the sequelae of that kind of trauma. I don't want to be erudite. I'm not erudite, but I was watching a fairly low-level crime show. I don't remember which one. And I learned that trauma is actually derived from the Greek word for wound. That's really interesting, I think. The trauma is about wounds. And so what do we know about wounds? Well, we know that there are really four major things we have to think about in a wound. Of course, we could have elaborate typologies about wounds, whether they're punctures or abrasions or whatever. But but we can prevent wounds, okay? We can do things to prevent them. Gloves, seat belts, all kinds of things prevent wounds. We can manage them, and that we can do with, drugs or environmental manipulations, bandages. There are host characteristics which impact on both the prevention, the wound, and the sequelae of wound, nutrition, community resilience, a whole variety of things. And then we can also try to prevent the sequelae of wounds, right? So that's kind of a useful model, I think, in terms of thinking about communities and in terms of thinking about wounds to communities and how those get healed. We can prevent the wound in the first place. We can try to add forces and resources that somehow buffer the impact of the wound, of the precipitating causes of the wound. We can manage it, and we can try to deal with the consequences of wounds. Now, normally when we think about trauma, we think about it occurring to individuals. So here's a little stick figure, and something's happening to that person. And interventions directed at individual trauma are important, and I don't for a minute want to diminish the role of that. They are important, but there are other things that we need to think about as well. So the first thing is that wounded once, wounded again, the trauma clusters within people across time, and there are traumatic events that occur over the life course that are predictable, that have to do with one's position in the society, that basically increase the likelihood of, if you're wounded as a child, if you're traumatized as a child, you're going to be traumatized as an adult. So there's life course aspects to trauma. There's also multiple traumatic events cluster. So for a whole variety of reasons, if you're exposed to one kind of trauma, you might very well be exposed to another kind of trauma. They're not sorted out randomly as if it was some sort of, random event. They have to do with a whole variety of characteristics of the society and the individual and the point in time in history that mean that people are going to be traumatized and have a higher risk of being traumatized in various ways. The other thing, of course, is that within areas, the blue is supposed to be a place, within areas, the same things that happen to one person happen to another person. They cluster geographically. Okay, we're starting to get a community sense to the discussion when we think about that. And that what happens to one person happens to another person. They may affect each other. And that in fact all those things are embedded within spatial and temporal and political and historical contexts in such a way that make the allocation of traumatic events a non-random event. And that even occurs for so-called natural traumas like hurricanes, because many of the things that are associated with those traumatic events will be, many of the things that help buffer the impact of those traumatic events will be clustered. Their absence or presence will depend on who you are and where you sit. Now, stitch in time. So trauma is usually thought of at the individual level. I can't read there. But communities can also suffer trauma. And community trauma can be acute, such as natural disasters, or it can be chronic, unnatural disasters, such as sustained poverty and chronically thwarted opportunity. In some ways, spreading as it does within and between communities, community trauma may be the unkindest cut of all. That is, community trauma not only affects individuals, but it affects the connections between individuals and the connections between individuals across places and across time and across generations. So dealing with trauma at that level is both difficult and important. I do think that prevention and management of community trauma may require new ways of thinking. I just had to read it here. New ways of thinking that range from the personal to the political, from the cells to the society. We have to avoid, I think, thinking about dealing with trauma at a particular level and try to build, in the spirit of this institute, an integrative approach to trauma which blends both the personal and the political. Now, an example of this, I turn to William Julius Wilson's work in 1996 called When Work Disappears, The World of the New Urban Poor. If you don't know Wilson's work, it's been very influential, a professor of sociology at Harvard. In 1996, his book highlighted the broad and pernicious and traumatic footprint of academic job loss in communities on the economic, social, physical, and psychological well-being of community residents. Importantly, and I think this is really important, he emphasized the external factors responsible for the extraction of jobs from these communities, for creating communities that had no work, and all the sequelae of that. An integrative approach may be needed to tie all of these elements together, the economic, the social, the physical, and the psychological, and free us to think between and across levels, society to cells. So the challenge, and some of you have seen this cartoon before, the challenge is to leverage our understanding at all of these levels to see if there's some surplus value we can get from such a leverage to prevent trauma and manage its consequences at the individual and community level. So that's just kind of preloading the discussion. We're going to hear a lot about some very important work done on healing trauma in communities, and I'm hoping in the discussion we'll kind of take that work, build on it, try to develop what a community and an integrative approach would be, and see where it takes us. So I, for one, and I'm sure all of you are looking forward to the presentations.
I'm going to come out with a positive approach, and despite what I know is a felt experience of despair that many people in the environment have around our possibilities, but I still think that we have many possibilities to promote community health and well-being by leveraging what we know and what we have within and between us. And there's a lot that can happen in the local levels that maybe will be more empowered than ever to be maybe on their own, but nonetheless empowered. So I'm from the Child and Adolescent Health Measurement Initiative, which was founded in 1996, to just ask the question, what are we up to in terms of population health and well-being for children, youth, and families? How do we measure it and get that data into transformational partnerships to really innovate and find out how we can improve well-being and population health? This is my quick triangular diagram of what I've been up to for the last 20 years or so. My goal is just to say a little bit more about human development and trauma as a background, possibility for prevention and healing, and really meeting the translational mandate, because there's so much that we know already, that you know already, that is ready for translation, and how do we start to fast track that in the ways that we approach the opportunity and the call to action. So I'm going to start with my punchline, which is I believe that well-being is upon us and within and between us, and that we live in a time when the science has accumulated to match our lived experience, which is maybe the most deep science of all, is our own lived experience, and policies meet. Now, I don't know what will be happening in the policy environment, but important policies that enable sort of financial models that give some freedom to health systems and communities to innovate have been on board. I don't know what will happen with them, but in any case, there's a lot of policy opportunities that we have now that we didn't have years ago. And obviously, it all points to ours as a social brain, like George is saying, and that knowledge about that, the social determinants of health, which we've had for a long time, combining with the neuroscience and epigenetics and even the management sciences around how we create change, really, I think, make what I'm going to say is relationships a matter of public health. So there's about 50 years of research that is linking safe, stable, nurturing relationships, and I define relationships broadly as not just between you and me, but between me and my environment, even my food, the earth, things like that. So I think we want to expand our concept of relationships, but I'm actually talking about those most developmentally important relationships with the mother and the father and the family unit being very connected to health early and across life, and the relationship in turn of those relationships to stress and to trauma that is intergenerationally often extended. So I'm not going to go through all this, but in 1968, John Bowlby began with the attachment literature, and about 2000, we finally had the Neurons to Neighborhoods report that the IOM and National Academy of Sciences put out, which actually is only now starting to get translated 17 years later, which they say it takes 17 years to begin to translate. And I think now we're just starting to see that Neurons to Neighborhoods report really be translated. And we're now in a time where we've had some studies like the Adverse Childhood Experiences study that I'm going to say a little bit about, and a plethora of community-based efforts that are really applying trauma-informed principles at the community level and at all kinds of levels, and in schools and in juvenile justice and justice departments and so on and so forth. So we have a lot of research that integrated together really point to a lot of possibilities. And also just anchor us in what are our requirements for healthy development and well-being. It's like we know a lot about what does it take to be well. We actually instinctively know this, but we don't translate it into our systems. But safe, stable, nurturing relationships are a centerpiece that are connected to social and emotional development, which many people will say is very linked to cognitive development and preliminary and interdigitating with it tremendously, which then produces positive health. It's very related to positive health, and positive health being defined as an experience of well-being. Things like hope and optimism, engagement, participation, resourcefulness, ability to solve problems in life. These are the kinds of positive health factors I'm talking about. And when we have those positive health factors and resilience, it's often because we have protective factors in our relationships, both within our immediate environments and in our communities. And that's really what the science, I think, shows us. In terms of the immediate environment, when you don't feel safe, and it's really important that you don't feel safe, not whether I think you should feel safe or I have the environment that should create safety, it's do you actually experience safety is very important. And if you're a young child and you don't feel safe, it's hard to learn. And we can see the early brain development impacts of lack of safety. And I'm talking about emotional safety, relational safety, those safe, stable, nurturing relationships. And depending on how those adversities are handled in the adaptation process, which is very impacted by protective factors, including environmental protective factors and so on, we have a direct relationship to adult functioning and health behaviors and ways of being in the world that either promote or undermine our own well-being. So how many of you are familiar with the Adverse Childhood Experiences study? Okay, so they say it's the largest public health study no one's ever heard of, and it started in 1996-97 out of Kaiser Permanente. They were doing obesity treatment and found questions that they were asking people to point to this inescapable pattern between early childhood experiences and obesity and failure to sort of be successful in maintaining benefits from the program. Dr. Vincent Folletti went to Robert Anda at the CDC, and they launched a study that's still kind of ongoing. And basically what they identified from a lot of prior research, because there's been a lot of research in this area, was a set of factors that really are developmentally oriented types of abuse in the home: physical or emotional or sexual abuse, physical or emotional neglect. And the neglect factor is really a major one, especially emotional neglect. A lot of people think that, you know, if I can see it and it's physical, that's a bigger impact, but actually emotional neglect is the factor most associated with cardiovascular disease in adulthood, is having had emotional neglect as a child. And then, of course, household dysfunctions, mental illness, substance abuse, having a parent that's incarcerated or dies early, and even divorce. And so a lot of research has gone into the selection of these few. Of course, there's many more, and there's also expanded ACEs, like what's happening in the community, neighborhood violence and safety, and so on and so forth. The main point here is that they're so co-occurring. They're so co-occurring that it's very, like you said, and cumulative, that it's very hard to, you could make a list of 100 things, but these 9 that are measured in the ACEs study really seem to be flagged out, and they're very related to what's going on in the community as well. So the CDC Kaiser study identifies that about 2/3 of the adult population has one or more of these experiences, which is not surprising. But once you get to 2, 3, or 4, the effects on health early and across life start to jump out quite strongly. And there's about 1,000 studies that are published at this point around this. And of course, the neuroscience and many of the other sciences are coming on to explain the mechanisms of effect that really link ACEs to multiple outcomes in these 1,000 studies that are available online if you'd like them. But I circled smoking, alcoholism, sexual behavior and patterns, obesity, but just a lot of the risk factors that we know are driving a lot of illness. And the research is pretty strong there, and very linked to our theoretical and empirical models of healthy development. So the environment of relationships is now standing out as equal to the physical environment or the built environment or nutrition as a factor in health and well-being, and how that interdigitates with the gene-environment interactions and accumulates over time depending on adaptive factors like protective factors that can occur. So I want to say a little bit about new data that we have. It's not brand new, but it's exciting because we haven't actually had information about adverse childhood experiences among children and youth themselves. And that's obviously a great public health opportunity, is to be able to find out what's actually happening, not retrospectively once you're an adult, but looking at children now. So we took us about 12 years to get a set of items, adverse childhood experiences items, included in the National Survey of Children's Health. This has to be approved literally by the White House. And so it's been a long trajectory, but we now do have data, and we'll have 2016 data in a couple months, that show that about half of children in the country experience one or more of those 9 experiences that I pointed out earlier, and about 25% or so have 2 or more. And when you get to be 2 or more, you really start to see early effects on chronic disease, social and emotional development, and so on and so forth. The range across states is interesting. We have 16 to 32% across states. When you do multi-level modeling, that still holds up as a variation, not predicted by demographic factors. So we have this geographic spread, very related to some of the things I think Dr. Kaplan was talking about around culture and so on and so forth. So I have some data on what it looks like in Baltimore, because we ran some data with Dr. Blum on the social determinants of health meeting that was a couple years ago. And so this is, I think, a handout that you can look at if you're interested in estimates for the Baltimore area. And it's not by neighborhood. So obviously the neighborhood effects would be huge, and we don't have data to go down to that level, but we do have some for Baltimore showing that about 31% of children and youth in this city have 2 or more ACEs. And by neighborhood, it'll be obviously a lot higher for many. So across demographic groups, it's as you may expect, much more likely if you're older, have more opportunity to accumulate. If you're in lower income homes, higher. But the racial disparities are not as high as you may think. And even for upper income, the prevalence is pretty high. So it's all of us is the punchline. And we look at also in the national survey, this was equally difficult to get included, is factors related to flourishing, which are really 3 things. Motivation, which is being curious and interested in learning new things. Self-regulation, the ability to stay calm and in control when faced with a challenge. And focus, the capacity to begin tasks that you choose to start. So it's really anchored to the child. And when the more ACEs, the lower those the children are to display those characteristics. But if you look, even though with those without, it's only 55%. So I think we're really living in a society where we're not looking at proactive development of positive health. And so the opportunity is there for all of us once again. This is just more data that you can look at later, documenting the higher rates of chronic illness among children with 2 or more ACEs already early in life. Also for young children below 5, the probability of having be at higher or moderate risk for developmental problems using standardized validated instruments is upwards of 43% if they have 4 or more ACEs, which is a large chunk of the population in many neighborhoods here in Baltimore, if not most of the ones we're most concerned about. I say it's equally unequal. A few things happened to my slides when they got put up on this platform, so excuse the funny look. I call it equally unequal because once you've experienced ACEs, the variation across income groups and the effect is not that great so far in the analysis. We can pick this apart further, but once you're 400% of poverty or above, you're equally likely to have an emotional, mental, or behavioral diagnosis. And this is using a lot of national data that is standardized and population-based. This is not showing my percentages, so I apologize for that. But it's about 43%, between 43% and having emotional, mental, or behavioral problems. And then, of course, it's intergenerational. What we see is that children with 2 or more ACEs, only about a little over a third of their mothers are reporting excellent or very good health status. And so we know that that's creating a density of trauma within the home that's often intergenerational, and that's a lot of the focus in pediatrics is looking at the mom and the family in order to address these issues, because there definitely is a relationship. If you want more data by state or local areas, here's a place where you can access a lot of what I showed you by state. So what can we do? The ACEs study, Dr. Falke and Anda have 4 recommendations. One is to routinely make people aware of this relationship between what they've experienced and her health today. And the purpose isn't to diagnose or to even screen, it's to create a healing conversation. So that we want to acknowledge their reality by saying, how has this affected you in your life? And to create some self-compassion that, did you know, I know you've had some experiences, it looks like you've had some experiences, what do you know about how this has affected you? And that immediately brings compassion in, because it's somebody validating, I know it's affected you, and it's not a problem. And so Dr. Falke would say that's the biggest impact of asking, is that it creates a sense of self-compassion. There's often a lot of embedded shame or even lack of awareness, and immediately there starts to be better health behaviors that they've noticed. They had a 35% reduction in, 35% reduction in outpatient visits after they asked about ACEs in practice. And so there's a lot of work to tie that to outcomes, but it's very important to do this. So it's more than a courtesy alert. I don't know if you get these on your dry cleaning, but I do often. So it's more than a courtesy alert because there's something we can do about it, and that's the exciting thing. And it's not the event, it's the experience of the event. So you and I can have the same event, it's the experience. And it almost doesn't even matter whether it actually happened. Did you experience it? It's again, if I feel safe, I feel safe. Whether you think I should feel safe, I don't know. We know from the epigenetics, it's our experience of what's happening that is really driving the impact and whether trauma occurs. So that's very important, and we have a lot of research in mindfulness and mind-body practices. I think we're suffering from a societal level, hard, easy cognitive bias. There's different studies here on the power of narrative and storytelling on your immune system that's been around for 20 years. Teaching teens about a growth mindset. Did you know that you're not static, that you actually are growing and developing and can throughout your whole life? Immediately reduces depression symptoms, and that lasts after a year. So we have a lot of data. We're starting to see it in home visiting, but not to the extent that we can and should. So we need to really move forward. I have a lot more slides that I'm not going to be able to show, but the main point is that family, community, and school protective factors make a big difference on whether the people who experience adverse childhood experiences and developmental trauma actually are able to attenuate those impacts. And they're about relationships and also experiencing community traditions, and that you feel safe in your school is just as impactful, it looks like, as those relationships within the home. So we can really do a lot. Once kids have resilience, which we can teach them, the probability they're engaged in school is triple or 2 times to 3 times. So we can teach children about resilience, and there's a lot more schools that are doing that, and we see a huge effect. The prevalence of health conditions goes way down once resilience is on board. And again, those factors that are promoting resilience among children have to do with relationships, having an adult mentor, sharing about things that matter, and whether the parents themselves are really stressed. So the programs out there that are dealing with parenting are often employing a lot of mindfulness-based techniques to help parents really become aware. And there's been for a long time, in fact, Dr. Brim, you might even have been involved in this New Horizons study 15 years ago, where we said we need to look at pre-disease pathways, positive health, gene expression, personal ties, healthy communities, inequality, population health, and so on and so forth. And it really has laid out a lot of things that, again, we're just now able to come back to. So I'm really into not reinventing the wheel, but picking up where we are and moving things forward. We have a national agenda we've put together on how to address trauma and improve population health in pediatrics, which I'd love to talk with you about. But the bottom line is to instill the mindsets that match the mandate, which is really a paradigm-shifting mindset about the importance of relationship and environment. Metrics to match the mindset, that's what I'm going to be doing a lot, is how do we construct metrics that can actually help us understand and learn and do what I call citizen science and real-time rapid cycle learning, and methods to move the metrics. So I will leave you with that and look forward to the continued conversation.
So thank you. We're just welcoming Kenneth Falke from the Boulder Crest Retreat Center in Bluemont, Virginia.
Let me just give a couple of disclaimers. One, I'm not a doctor. I'm not a mental health specialist. I was a bomb disposal guy in the Navy for 22 years. I come from a profession of mistakes. Normally only happen once. If they happen twice, you're what we call lucky. So I got involved in wounded warrior care. My wife and I started a small charity early in the war just to take care of wounded bomb disposal personnel and their families. That inspired us during 2 years of combat. We had 71 amputees over a 52-week period of time. So we start bringing these families out to our home. We see a very interesting reaction to getting out of the hospital early on in these stays. The average amputee inpatients for 90 days, the outpatient for 12 to 24, 36 months, depending on the severity of the injuries and the wound management. So that inspired us. We donated 37 acres of our land. You saw what ended up on that. And we're in the process now of buying a place in Tucson, Arizona to have a West Coast, East Coast version. What inspired the post-traumatic growth work, which I'll just give you a little insight in, is after a lot of frustration to include an Army colonel who showed up at our place on 37 different medications. 37 different medications issued by 3 DOD and VA hospitals. And let me just take one step back. In 1989, I broke my back in a parachute jump. I was told initially I would never walk. The first phone call my wife received was that I was dead. 9 months later, I was back on full active duty thanks to chiropractic treatment. And in 1989, in this country, chiropractic treatment was witch doctory. So I'm a big believer in alternative care, which has kind of led me on this journey. So I went to Harvard, went to the University of San Francisco, I went to Palo Alto, I went to the VA Center of Excellence for PTSD, and every doctor, man to man, woman to man, every doctor I talked to said, the current system doesn't work. I'm thinking, well, if it doesn't work, what the hell are we doing it for? Why are you medicating these guys? Why are you bringing them in here, talking to them like they're children? If it doesn't work, why are we doing this? And then I meet this guy out in Napa Valley, Fred Guzman, who's been doing PTSD treatment for years. He has a 6-month inpatient program that includes detox. And I said to him, well, if you're having all this success, why aren't we putting this into some sort of curriculum and changing the way the system works? He said, I don't have the staff, I don't have the money, I can't do it. So I went out and started looking for money, and I meet this guy, Dr. Rich Tedeschi at the University of North Carolina, who's the father, coined the term post-traumatic growth. I think if you read the Bible, the concepts of post-traumatic stress or post-traumatic growth date back to biblical terms. This concept that in the deepest times of struggle after combat, that we can take a knee, find the opportunity to take a knee, and to really do some self-introspections, things that we don't necessarily get to do all the time. And that's really what this program's about. You said the right arrow? So here's the first thing that we believe. The first thing we believe is this quote from Thucydides, that one man is much the same as another, but he is best who was trained in the severest of schools.
And he's talking about combat veterans, people who come home to this strength of growth, right? Now, I've heard the term resiliency a few times. In the term of human resiliency, I'm not a big fan of it, because I always think of resiliency as this, literal definition of the ability to bounce back. Now, military combat veterans, let me just give you one example. We learn to sleep under our Humvees, hang hammocks in the back of airplanes, sleep while we're getting mortared, sleep while we're doing this. And then we come home and somebody wants to give us a weighted blanket because they feel the weighted blanket is going to let us sleep better at night. So we believe that there's a level of strength here that needs to be treated rather than treating them like children. And that's what this quote really was about. Thucydides saw that warriors come home and take care of their communities through service. If you look at the concept, the framework of post-traumatic growth, the ultimate indicator, if you measure post-traumatic growth indicators, is service to others. And that's why we serve the military. So these are just a few quotes. You can have these slides, I think, if they're going to get shared, but everybody, over and over, including the Journal of the American Medical Association. We need a new and innovative approach. That's not me. I believe it, but it's not me. So what this program is, this 18-month program that we're focused on. We got about almost $1.2 million last year to build a curriculum around it and to do an 18-month longitudinal study. And we have 2 clinical psychologists doing that. And it's really an interesting study. It's studying about 250 questions that are focused on some of the traditional mental health stuff, PCL scores, depression scores, those types of things. But what we're really measuring are what we call the post-traumatic growth indicators. Things like improved relationships. We talked about, or you heard from Christine, the divorce issues. In the military, historically, our divorce rates have been higher than society. Society in this country is about 50%. We're about 55%. In the special forces community today, 95%. So talk about childhood trauma. Fathers deployed, mothers deployed for long, long periods of time. Then they come home, they can't get together. Whatever happens in the house from a domestic violence perspective, and that all goes back. The Blue Star Family Association, which is the family association for military families, did a survey on military families, asked military families how many of them would recommend military service to their children. Less than 30%. Now let me tell you, in our country, we rely on a strong defense. And that strong defense has normally been a family business. Your dad served, your grandfather served, you served. That's the way it goes. That's the way we get most of our recruits. This is a national security issue. If we can't recruit, this is the first war we've ever fought as a country with an all-volunteer force. So it's a pretty serious thing. It's not just about some trauma that guys bring home from war. You go to war, you're going to come home with trauma. It's just the way it is. Right? You go to war, you do bad things to bad people, you see lots of bad things, and you're full of, trauma. But we also train people. These are the indicators. If you don't know much about Tedeschi's work at UNC Charlotte, these are the indicators of post-traumatic growth. This whole concept of going through the process. Talk a little bit about, just because Christine talked about the childhood trauma and the center step there, the disclosure issues, the family trauma in our military personnel is in fact horrendous. Many of our recruits come from the inner cities. People leave the inner cities to come into the military. I'll just give you one story of a Navy SEAL, 27 years in the Navy, was going through our program. We have a disclosure, about 2 or 3 hours of disclosure where we get into childhood trauma and the ACE types of trauma that occurred in the family. And sure enough, this kid for 3 years of his life had been sexually molested. Went to Afghanistan, saw somebody sexually molesting a child. He killed him. He violated the rules of engagement. He was thrown out of the military. And now he's living with all that trauma, not only the childhood trauma, but the way that he was discharged out of the military. Josh in the video said this. We talk a lot about the education process. Our belief is this, in that no matter who you are in life, you're going to live a life that's full of ups and downs. And And the way we try to keep people in a livable band is through creating a real good support network and relationship structure, and then giving them those wellness practices. The cornerstone of our Warrior Path program is transcendental meditation. We focus on 4 areas of wellness. One may be kind of foreign to you, which is the bottom left, and that's the financial element of it. Many of the suicides that we've looked at in the military today, about 20 veterans a day kill themselves. 20 veterans a day. It's the only cause of death in our nation that's on the rise, suicide. 20 veterans a day take their own lives. Most of them are 55 years or older. Most of them didn't deploy to Iraq and Afghanistan. Most of them have severe financial problems. The ones we've looked at very closely. So the wellness, in our wellness model, we're focused on 4 areas of wellness: mind, body, spirit, and financial. We talk a lot about this in the education process, the medications, the bad influencers. I won't go through all this. But here's the punchline of kind of what we've come to realize, is that it's not about therapy, but it's about training. Because if you look at the symptoms of PTSD on the left side of this chart, you look at the center of that chart, that's what we train people to do in the military. We're almost like training them with symptoms of PTSD. Then they come home and they don't get taught how to turn it off. I always tell people, the military loves you when you're big, strong, fit, and deployable. But the minute something goes wrong with you, they're not really that good to you. The VA, arguably, depending on what story you read today about the VA, arguably the VA takes care of you when you become qualified for VA benefits. But in that middle area, what I call no man's land, there's not a lot of good stuff going on. We threw lots and lots of soldiers and Marines into these warrior transition units. They were actually in there taking drugs, sharing each other's drugs, sharing each other's stories on how to game the system. So what we're trying to do now is figure out how can we resolve that part of the problem. And that's training them to learn how to live with what we trained them with in the military in a healthier way. So we have a labyrinth on site. Everything we do has some sort of a therapeutic process to it. We don't just do archery. There's a meditation that starts it off. There's a metaphor around why archery is important, etc. Same with our art therapy, as you can see, the mandala work. Every night we close things with a fire. It's a warrior tradition, just in general terms. And then we try to help them create this new and positive story, which is very instrumental to post-traumatic growth. And I think that is it. So any questions? I'll be around for a little while. Thank you.
And again, we'd like to welcome Andrew Masters, who's with the Baltimore City Health Department.
So hi everybody, my name's Andy. I am the Youth Health and Wellness Lead at the Baltimore City Health Department, but that's kind of my day job. I'm also the project director for a grant that the Health Department recently was awarded from SAMHSA called RECAST. It stands for Resiliency in Communities After Stress and Trauma. So I'm just going to give a little bit of an overview of how we got to where we are, and where we're going with this. The first is about, sort of where we started. So SAMHSA released the FOA in April of 2016. It was actually in between my last job and my new job. So during my little bit of time off, I was working on this with the health department. So what happened is we saw a federal grant opportunity, 5 years, $5 million. We said, great, we can do a lot of good work with $5 million. So we called together people that we knew in Baltimore that do really good work, that we've worked with on other grants, that, some other folks that we've heard of that we wanted to bring in. So we created this plan. We got a budget. We said this is what we're going to do to meet the basic requirements, the required elements under the FOA. And we were required to engage the community. So we built out this budget, and first of all, the health department committed to taking as little amount as possible. We didn't want this to be, a top-heavy grant. We had heard that all throughout the time since the uprising, that there was a lot of money coming into Baltimore, but not a lot of it made it to communities after all the administrative fees, we'll call them. So we also made sure that we set money aside to go to youth-led organizations, because we know that doing the work in Baltimore, following the uprising, there was a lot of youth organizations, youth-led, youth-serving, that really expressed a need for funding. So we withheld a portion of the funds and said, okay, so we'll reach out to the community and get their feedback, because that was required. So we emailed a whole bunch of youth-led organizations, community members, to sort of present our plan and show them how awesome this idea was that we came up with, right? So we met at Douglas Memorial Church in West Baltimore, and I'll just say we were eviscerated by the community. We sat down, we told them all this stuff. We were like, way exciting, because we got money to give out, a little bit of money, like $170,000 out of $1 million. And what we heard is that we're tired of white-run organizations coming into black communities telling us how they're going to save us. You know, we're tired of processes where we are the end result as opposed to the beginning of planning. You know, there's a lot of organizations in our communities that are doing this exact same work, and you just don't know who they are. You know, we heard from community members and some of our own partners who said, you know, if you're not at the table, you're not on the menu. You know what I mean? And so what happens in grant making often is that people you know get more grants. So the rich get richer, almost, well, literally, as we think about the next bullet of institutional and historical racism in Baltimore and other places. They said things like, we don't have as much of an issue with the outcome, right? We might have come to the same partners. Our problem is with the process. You know, and so it was a real gut check, right? Because we were a group of white folks talking to a group of black folks, and they were using words like racism and white privilege, and it was a real gut check. Like, it was, you know, and what happened is my boss, Rebecca Deneen, the Assistant Commissioner of the Bureau of Maternal and Child Health, you know, we had to sort of face this thing that we kept saying we were about racial equity. And here was an opportunity to actually be about racial equity. So she really quickly pivoted. We said, we will share the budget with you. We will get your feedback, and it's not too late for us to make changes. So we said, why don't we meet back at the Penn North Library in a week, right? And that Penn North Library was really symbolic for us, because that was the library that took kids in off the street during and after the uprising. It was where folks were able to go and get meals when schools were shut down, rec centers, you know, weren't open all that long. And so that library was really important to us. So we met there in a week. We had something like 65 people in the room. And we didn't end up getting a whole lot of feedback on the budget. You know, but what had happened is that, you know, we as representatives of the health department did a couple of things. One, we openly acknowledged our institutional historical racism and racist practices. You know, and for us, racism isn't just like extremist groups. We recently went through a training with the People's Institute called Undoing Racism, and in that they really challenge us and say that racism, all white folks are racist, because racism is benefiting from a system of white supremacy, right? And so we had to acknowledge that. We had to own that, you know, not comfortable, not necessarily happily, you know, and just to say, like, when we look around the room, I don't see a whole lot of folks of color, you know, and that to us is something else. You know, when we look around the health department, we don't see a lot of folks of color, especially in leadership positions. When you look around most organizations, you don't see a lot of folks of color in decision-making authority, you know, and so for us, they called that out for us, and they said, eventually we came to these three principles that we would go under, and the first principle is, so the first principle is that this grant will be community-led and community-driven. that our larger white-run institutional partners will commit to hiring locally, subgranting locally, and building the capacity of smaller Black-run community-based organizations. And third, that our larger white-run institutional partners, funding will be shifted away from those institutions and directly into the hands of small Black-run community-based organizations, right? So our partners know going in that their budgets will shrink. There's no surprise there. We started meeting weekly with that community coalition. We didn't have any money to do that. That came out of my pocket. I don't know, I still don't know where I found that money, but we did feed them because you can't have community folks come out and not feed them. I don't like having anybody come out to donate their time for something that I'm getting paid to do, right? And so at that time, all we had was money to feed. We met weekly and we continued to learn from the community. I remember we walked in and, again, a bunch of white folks coming in front of a group of Black folks who live primarily in public housing. They live in that undercurrent, that constant trauma that folks in Central West Baltimore experience on a daily basis. And we said, here's Samson's definition of trauma, right? We put it on the board. And let's talk about that. Right? Because we're experts. We know trauma. We've got this, federal government definition of what trauma is. And we very loudly, very emotionally were told to sit down, shut up, and let us tell you what trauma is. Right? Trauma is walking past police tape to take your kids to school. Trauma is hearing domestic violence in the next room and not knowing what to do. Trauma is having to do sexual favors with public employees to get your condo fixed. Right? That's trauma. Not that SAMHSA's definition is SAMHSA's definition, it's fine. But that doesn't resonate with communities, right? We again had to check ourselves. So what happened? The next week we came back and we had small group breakout discussions, right? And we had them run by community members. And all the white folks were told, sit outside the circle and listen. And you're not allowed to take notes. Because too often, when a white folk person is sitting outside a circle of Black folks taking notes, the conversation's not real. And so our presence simply as white people from the Baltimore City Health Department, which has its own history in Baltimore, right? We were told to sit down and be quiet and sit in the back and observe, right? So we submitted that grant. We submitted it. We submitted it with a budget that had $170,000 unallocated. We didn't say where it was going to go. And if anybody's written federal grants, you normally have to say where every penny's going, who it's going to, how you're going to account for it, and what their outcomes are. But us, we left $170K on the table. We took it, but we just didn't say where it was going to go. Because the other thing we had committed to is that community coalition would develop a board of residents and stakeholders. But it was 10 residents and 5 stakeholders. So the people who live in the community, the people that were going to benefit from the dollars, were placed in charge of where the dollars go. And our partners were told that they are programmatically accountable to both the health department and that community board. Right, so we're placing community folks from public housing in positions to allocate several hundreds of thousands of dollars over the period of this grant. So the coalition continued to meet, right? We said we submitted this grant, now what? They said, well, we still work here, we still live here, let's still meet here. On my dime, of course, but that's okay. So the group continued to develop those board guidelines, discuss the needs and values of the group. And we talked about this as being a unifying body, right? Because we've heard all the time, and frankly, there's plenty of money going into Baltimore, right? Like there's plenty of money going into communities, but it never makes it to the community, and it never makes it in a way that brings all of that funding together around a common vision. Right? Every funder has their own thing they want to do, both private and local and national. They all have this niche that they want to fill because that's what their board is interested in. Right? And let's think about who's on philanthropic boards too. So what we did is we said this board, this group is not just about this grant. We want to make this group about all the grants, all the programs that are in Central West Baltimore, right? So we reached out to other folks that got funding right after SAMHSA closed their deadline. The Department of Education released another grant promoting student resilience. SAMHSA also gave a grant to Behavioral Health Systems Baltimore, and all of those grants are using the B-City Coalition as its community leadership arm. Right? So now not only are they directing $5 million for us, they're directing $2.3 million in PSR, and they're directing another $470,000 a year through U-turns. And not only that, but we're all working towards that same vision, those same goals, and making sure that we're not duplicating services. You know, so we did get awarded the grant. We were the only city to receive 3 years of funding up front. Everybody else, the other 7 cities, just got $1 million. We got 3, right? Proverbially in our bank account, you know? So that way nobody could touch it, no matter what happened in November. And we continued that community leadership piece. We had a grantees meeting 2 weeks ago in Rockville, you know, and all 8 cities came together, and we were supposed to listen to SAMHSA and all of that stuff. So I went. And then we brought partners and community members, folks from Central West Baltimore, right? Like, everybody else brought like big wigs, right? They brought agency folks. It's a trip to go to Rockville. Folks are coming from Oakland and San Antonio to go to Rockville. You know, but we brought folks from Baltimore. You know, we brought people that just lived in Baltimore, lived in public housing. We brought folks that, you know, just work here. They grew up here. They live here. They bleed and die here. You know, and we changed the meeting. You know, everybody else had 6 people, we had 12. You know, we're Baltimore. You know, and that was important for us. I don't need community build or coalition capacity building from SAMHSA. I need capacity building for my community members. You know what I mean? They want to understand what's happening in SAMHSA, but they also want to tell SAMHSA what SAMHSA needs to hear. You know, so part of what we have to do is hire a project manager. How much time do I have? Am I good? 2 more minutes? 2.5. Oh, geez. So when we submitted, we had to put in a project description, a position description. But after we submitted, we said, okay, now what's it actually going to be? Right? And the biggest thing that happened there is they said, if you require a bachelor's degree, you're going to alienate just about all of us. You know, and they said, you know, we heard like, if I've been organizing in Gilmore Homes, what is a bachelor's degree in sociology really going to teach me? You know, if I've been slinging on the corner for the last 5 years, why do I need your accounting degree? I've been keeping track of all of that stuff without a bank. Right? So we opened it up and we said, or demonstrated experience. And then we posted. We didn't tell anybody else about it except for the community. And we said anybody from the community gets an interview. Unfortunately, nobody from the community applied. But our first round of interviews, we had community partners on the panel. Our second round of interviews, we told our participants, our 4 finalists, that they had developed a presentation to give to the Community Coalition. And the Community Coalition came up with 6 questions, and they all had a rubric to score the presentations. And they were the ones that ranked the candidates. And they gave us the 3 finalists, and the health commissioner met and had no problem with the first person. So essentially, and actually, the Community Coalition hired the project manager because it's their project manager, it's their project. So what do we have to do next, right? We have to finalize that community board. We have to develop a strategic plan, and for us, that strategic plan, well, we first started with like services, this is what we're gonna do for you and with you. What we realized is that means that in 5 years, that stuff all goes away. So what we wanna do is shift to a more ecological approach, where some of our strategic plan is gonna be at the policy level. How do we advocate for policy change? To get other people to check their racist and historical practices, right? And then at the service, community, and individual levels. We have to develop an MOU, that's part of the grant. And I told my project officer, I don't want to do that, right? Because an MOU has to go through all those legal departments, and once it's signed, it's done. I said, and the problem is, our community still has money to allocate, so we don't even know who all the partners are. So instead, we want to do a statement of commitment, right? That as people come in, they can sign it. Yeah, it can meet all the same requirements, but I don't want to have to go through my legal department because they're going to mess it up because they don't get it, right? So For us, there's a lot still on board. Somebody asked me, how do you engage with the community? That's easy. Give money to community organizers, right? 2 of our 7 partners are community organizing groups. So they go into Gilmore Homes, McCullough Homes. They go and get people to show up. No Boundaries Coalition, their job is to organize young people, right? Like build that youth advisory group, that youth leadership group in there. I was talking to another city and they're bringing their cabinet together, right? The mayor's cabinet. And that's cool and all, but that's not going to make the change in the community. They have no idea how to get community. And I said, give money to community organizers. And let the community then make the change at the mayor's cabinet, right? Through the power that exists and is inherent in communities.
So we've heard 3 really strong presentations, one laying out the scientific basis for understanding the impact of childhood trauma on childhood and later events and policies related to it. Another on a very innovative program to address a deeply wounded group of people who have been asked to give a lot. And a third about the challenges to working in communities that have been historically excluded from the process of making change. Really covering a really wide territory. I thought perhaps we'd start by maybe having each of the presenters take a minute or so to talk about their response to the other presentations.
Mostly, I just wanted to say that, I didn't get to say everything that I was going to say, but one of the things was really one of the big innovations is this is self, family, and community-led healing. And that the policies that need to enable this include being able to pay community health workers, family to family, and that's a huge piece in Medicaid, for example. So we've been working with the Medicaid Medical Directors Network who get what you're saying, actually. And then how do we create a system that can actually fund those family-to-family, peer-to-peer workers in the community? And what are all of the credentialing and training? Is that even important? You got to do something, right? And so I think that it's really important to border all of these innovations with the policy and community, the policy at the national, state, and local level with the community in a really integrated learning forum, because you're going to hit a wall. If this works, then you're going to want to make sure that it's paid for, and the same thing with you. So getting back to the 3 M's that I was talking about mindsets and metrics and methods, those metrics end up being really critical. And the methods, like the community to community kind of pieces, really, how do we learn from you and go way upstream now so that in 5 years when you come out with your data, we can actually match it with the policy. So that's kind of really my main response, is the importance of staying really grounded and then, moving it into policy. And I think the metrics piece is a key bridge, as well as the feedback to the community. They're going to want to know, how's it going? How are we doing? Are we getting better? That feedback loop piece, both for them individually as well as at a community level. So the data piece, I guess I wanted to.
Thank you.
So first, our community board still exists, so they are giving feedback to the partners, and then our evaluator, they're hiring a young person from the community to be like a co-PI, so that they're building capacity from within. But I was really impressed, Ken, with the for us by us type of thing. That you're not bringing in a whole bunch of psychiatrists, psychologists, and all these other folks to do stuff to people, right? That instead it's vets, right? It's other vets, it's other folks that have been through trauma that are helping folks heal. I think one of the things that we've heard a lot is we don't want to use the word traumatize people, right? Because traumatized really puts it as an internal thing. And I was using the terms people who've experienced trauma or who are victims of trauma, right? And then another guy pushed back on me and said, no, we don't want to be victims, right? So I think I'm still unsure of the language, right? Like, and I think that language when it comes to trauma is huge, right? And so how to encourage, especially grown men, right? Like primarily grown men who have experienced those things. And like you talked about the disclosure piece, and that's huge, especially for, you know, guys that have spent all that time sort of hardened up. I think that would be, I can't even imagine that I would be able to survive one of those sessions without just breaking down. So I'm in awe of the work that you're doing.
Well, I would say the same back to you. Is it working? Number one. I would say the same back to you. You know, our goal with military service members is to get them back into places to serve. You know, it's when you look at a military operation, even at the most tactical level, it's very complex. And what I tell these, you know, the Marine Corps has a saying that don't let the Marine Corps be the last greatest thing you do. And that's what I tell everybody that comes back through Boulder Crest Retreat is now you've got to go fix these problems. Right? I live in the richest county in the United States, Loudoun County, Virginia. We've got a food bank that can't keep food on the shelf. We have a women's abuse shelter. We have MS-13 gangs. We have a heroin problem. And these are leadership roles that veterans, combat veterans, can come back and take. And that's what I'm so excited about, is to see if we can fix some of these problems at the community level.
With real leadership. So I'm excited about that. And then the childhood trauma, I just, people look at me like I have three eyes when I tell them that Navy SEAL story, but it's, and I've talked to the highest people at DOD and the VA, and they don't even want to talk about it. It's insurance, you know, one guy said, well, that might be a pre-existing condition. I'm like, come on, right? We bring people into the service. Again, the Marine Corps says we transform ordinary civilians into Marines. We'd have these recruiting commercials on TV where this guy's slaying this dragon. And at the top of this rock, he's standing there in the most beautiful blue Marine Corps uniform. And then we throw him out of the military, and every commercial on TV is this poor guy in a wheelchair who's broken. And we've created this story over the last 15 years, nonprofits have, to raise money to make this sympathy thing. It's like, you know, adopting a puppy dog. And this isn't what combat veterans are about. If you treat combat veterans that way, it's going to be hard to get ones in the future. And that's what I worry about, is much more complex policy issues than treating PTSD.
Hey,
But
why don't
thanks.
we open it up now, Paul.
Number 5.
Is number 5? Oh, number 5 is working. First of all, thank you all very much. I thought there were 3 fabulous presentations and very moving. My question really is for all of you, I think. And I want to ask you about the context specificity of what you do. To what extent you think the approach you take is transferable to other contexts? And an allied issue of the sort of one-size-fits-all problem that besets traditional medicine, the concept that, you know, there's a drug that'll be for depression or whatever. And that's a failed policy in a sense. And I'm very interested in the issue to what extent community-based approaches could potentially suffer from the same sort of problem and also could be hugely context-dependent.
I'll take the first step. It's number 1. So our motto at our retreats, Healing Heroes, one family at a time. In the last 15 years, I've given away about $30 million through one of my nonprofits. Personally, I've probably given away more than 2 of my own money. I came out of the business world. I ran a successful business that I sold and made a little bit of money, which has allowed me to do this. I have been appalled by the way a lot of nonprofits lead and by the way our policy makers, especially with these grants, require them to provide evidence-based metrics, whatever it means. Our motto at the retreat is Healing Heroes, one family at a time. You ask any nonprofit what their number 1 metric is, and it's normally how many people they serve, which I think is absolutely horrific. Because it is, to your point, it's going to create this model of the pharmaceutical kind of solution, one size fits all. So our programs are very small. They have an opportunity. We have, most of the time in Warrior Path, we have 6 participants and 6 providers. So it's a very one-on-one model where you can see where, now there is a curriculum, obviously it's a training program, so there is standards, but what we always say is don't train to to the time allotted with these standards, but train to the individual. And that's what we're trying to do. And we do it. We do it in the military. It's the way we train. I mean, we teach thousands of people a year how to safely jump out of an airplane. We teach thousands of people a year how to safely shoot a weapon and how to handle explosives or whatever these very high-risk things are. I'm convinced we can do it, but we're very cognizant of that issue.
Me? Okay. So I think what we took away most from this, right, the outcome for this grant, right, getting the grant and having the outcomes and having the services, for the health department, or at least for the team of us, that wasn't the most important part. For us, it was the process that was transformative, right? It wasn't the grant itself. It was the idea that I can only talk about me. Personally, I typically walk into a room and I think I'm an expert, right? And I act accordingly. And it was important for us to consistently get checked that when it comes to Sandtown, Winchester, Penn North, and Upton Druid Heights, I know very little, right? And instead of walking in as though I'm the expert, first I need to become the student, right? Like first I need to know the neighborhood context. I need to know what the hierarchy is within that community. And then I can slowly bring whatever it is expertise that I have and offer to, right? I think too often, again, speaking for myself and probably represent a couple of folks, I come into a room and I come into a situation wanting to impose what I think I know on what I think they need, right? To outcomes that I think we should be driving at, you know? And so I think the context that shifts for me and is applicable in just about any other situation is that I need to come in as the student first and the expert second, right? And that's in a group with professionals, right? That's in a group of community members. I used to be a school counselor, right? That's in a group of kids, you know? I think the community conversation model does vary, you know, like, but it's not a script. Like what happened in Central West Baltimore might not have worked in McElderly, right? It might not have worked in, in Northeast Baltimore. It might not have worked it probably would have worked though, in Cherry Hill. Right? Like it depends on the community. It depends on the level of cohesion in the community. But what I know doesn't work is what we originally tried to do, you know, and I know that for a fact. And what we have done though is taken this idea of servant leadership, right? Was essentially like sort of the way that I've tried to put it into words is that like we've taken that to other places in the health department, right? Our Be More for Healthy Babies strategy is now creating a community advisory board that is going to actually advise, not just check off a box that says we did this. You know, our teen pregnancy prevention initiatives, Youth Advisory Council is actually having more and more and more direct control over what happens around teen pregnancy prevention. You know, this idea that we are facilitators and coordinators more than we are experts and doers.
Your question is the right one, and that a lot of people who have been working in this, at least the science part, is that we need to enter into an era of experimentation, and that what works for whom. And there are common elements, pieces that are, you know, good places to begin. But really it has to be owned, and the engagement process is how you learn. So then the challenge is really creating a learning system. How do you create a learning system? What do you put in to fuel innovation and implementation with rapid cycle learning and feedback, with the capacity of people to listen in the micro moments, did that work, did that not work, and be willing to get feedback, which is not a small thing, okay? And then how do you do that? So really the innovation ends up being about learning and then getting that process moving. And that's really where I think the innovations are about process, but also having, you know, how do we fuel innovation implementation? We need a living evidence feedback loop. We need, you know, create champions at every level, because as soon as you create champions, new person comes in, right? The guy goes to college and you've got to keep it going. How do we create a learning system? So I think that your question's the right one, and that with that kind of system that can learn from each other and with documentation, we can start to figure out the answer to your question. But we have a lot of the raw material, I think.
Yeah, I didn't have my glasses on, I'm sorry. So this isn't so much a question, but something I think to add to the conversation. So I'm Leon Henry, and this is Robert Bethell. We both work in Baltimore City in a program aimed at working with current and active people who are involved in either formal gangs or neighborhood crews. And one of the things I think we see, I can speak for Robert, every young person who we encounter, who we have conversations with, who are involved in gangs or street corner boys, et cetera, I would say every one of them, when you dig deep, is a traumatized child. It's seldom that we see a young person who grew up in a happy, healthy, stable home who decided, I'm going to stand on the corner and risk getting shot to sell drugs and really not make money. And so talking to these guys, you really do get to see that all of them are suffering trauma. The other thing, similar to what these young men go through coming from the military, is I think we do see PTSD as well. When we try to get guys off the street and into jobs or into what we call regular society, it's a difficult transition. When you live a life where literally any day could be your last day, where you're engaged in combat on the street, that's a difficult transition. We want, as a society, we want these guys to stop selling drugs, put the guns down, and get a job. And we find that sometimes when we place them in jobs, because of the traumatic experiences they have, they can't function there without that therapy in between. So if you're used to being on a corner and handling aggression a certain way, when you have a boss redirect you, your only response to that is aggression. And so you lose your job and you're back where you started. So that's one of the things we see. The other thing, and I'll close with this, when we pick up the paper and we hear, unfortunately, that we lose someone to violence, society, we often look at that and say, well, that's one bad guy that's off the street. But if you go to the funerals of these young men at 25, 20, 21, you see the impact on whole communities. So that 25-year-old is someone's big brother. That's someone's uncle. That's someone's favorite cousin. That's someone who picked up a football and threw it with the kids in the neighborhood. What we read about, we think all of these guys are just these nasty, dudes who would shoot you, if you looked at them wrong. Well, first of all, most of these guys don't shoot, but their persona at home is different. And so in their houses, not only may they be the breadwinners, but they may be sometimes the most positive person that these young people have. And so when they do get killed, there's a lot of trauma that goes around with the younger people in their families and in their communities. The same stuff you were talking about. Not only is it going past the yellow tape, it's my big brother, my cousin, my favorite neighbor who was really, really funny, got killed. Thank you.
Thank you. I want,
Sure, go ahead.
So we talked a little bit about the mindsets, and trauma-informed is a term that people use, but we've been doing some work with the prisoner reentry work in California, as well as schools being trauma-informed, and it really is a paradigm shift. Like, to take that radical step of absolutely no, we do not dismiss kids from school no matter what, and we expect certain things because we understand what the normal behavior would be in the workplace to engage the workplace, and really to be riding that edge and support the workplace too, because they have issues they have to deal with. But how do we get into the nitty-gritty of really what it means is so important. So I just want to say that there's some models out there. I don't know what you guys are doing, but how do we really be trauma-informed and to go beyond informed to responsive? Because it's really about actually doing something different. Not just knowing something in your head and we stop off on it, oh, I know it, but then how do I behave differently in that moment? And what are the different ways I can be trained to do that? It's key.
Yeah, if I can, I'd like to build a little bit on some of these comments which rightfully criticize the inordinate role of expertise in helicoptering in and telling people what to do. But one of the side impacts of that, I think, is to suggest that there is no room for things at the supra community level. And I'd like to give you an example of one policy in California and other states as well that actually is having an enormous effect, and that's the ban the box movement. So in many states, in many communities, when you apply for a job, there's a checkoff to indicate if you've ever been convicted of a felony. Now, if you're talking about communities that have outrageous levels of incarceration, you're talking about sometimes 40 to 50% of the young men who can't get work because of that, because it's used to screen them out. So in California and some other states, there was a state-level effort to make it illegal to ask about incarceration history on a job application. In other words, if you want to hire somebody, ask what their qualifications are, what they can do, not whether they made a mistake or whether they got time for a drug, for a offense that's very unequally distributed. So that, I think, is an example of an integrated approach. You both have the issue of skills, of moving from one social niche to another, of the community, which suffers because of the high levels of incarceration, and you have a policy which actually can have an impact on creating opportunity, landscapes of opportunity for people. So I think we have to, I'd be interested in hearing other people's response to this. I think we have to sort of keep open to the ability to be working at all levels, not just at the community level, which is very important, and not just at the policy level, which can be very important and can also be very wrong. And somehow do that dance that allows us to move in between. Yeah.
I wasn't ready to speak. Let me thank the panel, first of all. And having said that, and I don't know most of you, but I have to tell you I'm feeling a little bit cranky. And it's nobody's fault. It's my little journey with this. But what I want to say is that we know that one of the highest morbidity today, one of them is based on social alienation and isolation. And we just had such a wonderful story. I'm sorry, I never could hear your first name, the warrior on Boulder Crest. Ken? I thought back to social alienation, lack of community, and that I believe love heals, that when you presented your story and what you're doing, we know that these things work. We know the people who are most succeeding in the society today are people who've had even mentorship, never mind getting to go to I'll call it a camp. And we know that the children or people on the autism spectrum, if they go to one of these high-class communities that nobody can hardly afford, they look like they get a lot better. So when Andy spoke with your dedication, but I thought most of us have been in healthcare for 100 years. And I thought, why are we reinventing the wheel every time? What you so honestly revealed, where the people were like, okay, here we go again, Groundhog Day. And I thought, why don't we have that pilot of Boulder Crest in downtown in Baltimore or anywhere? I think somewhere a million years ago I read, if we had a major national crisis, the two people or two groups that would succeed and win were the soccer players and an African-American church community, because they knew how to build community. And I'm thinking, we have such great models for what's your example. It's what we all need. But I don't know, maybe you can tell me there are some other models that are being implemented in this very practical way. And the funny feeling is just because there's so much smartness in this. It's like, let's get going. Let's don't redo this again with the people. Everybody's so frustrated, including me. Thank you.
Thank you.
Thank you. First of all, thanks for being cranky, because I get cranky too. I was an enlisted guy in the Navy, and I always got frustrated with policy, because when you're out there doing the deed, and it's a lot different when somebody whispers in your ear, that's not what the book says to do, and it's not the truth. It's not the ground truth. What I'll say is, first of all, my director's strategy would be very cranky for you calling us a camp. Because that's one of the, I say a lot of times, I wish we wouldn't have called it a retreat, because a lot of people get sidetracked by that comment, because I think we're onto something big here that is transferable into the civilian community. And we've seen that. I had an NFL football player, an Oakland Raider, come through the program. A friend of mine called me. This guy's played 4 years for the Oakland Raiders, lost his mission and purpose because he tore an ACL. He couldn't play anymore. He was at home in Dallas. He had a lot of money in his pocket. The NFL was paying him a lot of money. Wife and 2 beautiful children. He was sitting in the basement all day playing Game Boy and smoking dope. And he came up to the program, and he had an Oakland Raiders hat on, an Oakland Raiders shirt, and Oakland Raiders sweatpants. And our first labyrinth walk is to leave a burden in the center of that labyrinth before you walk out. And he got in the center of the labyrinth, and he literally stripped his Oakland Raiders stuff off and left it. And today, this is a young African-American guy that grew up in Arkansas, had to dodge people who were trying to run him and his sister over on their ways to school, and now he's back at home with a brand new startup nonprofit that he's personally funding, trying to get children through school. So I'm convinced this thing's going to work on both sides, and I do think that we're onto something there.
I just wanted to say that what you're cranky about is what I'm cranky about, and that, you know, we've had resilience literature for 50 years, starting in World War II, to really show that it's social connection as the core of it. Relationships are preliminary to even getting that individual capacity on board, that's where it begins. So I just want to say that I totally agree with you, and that's the innovation, because it's this hard, easy, you know, cognitive bias where we think it's supposed to be easy to do social connection, but it turns out that it might be the hardest thing, because it requires engagement of our personal being, vulnerability, and learning a new way of being in systems, and learning, which is defensive. People are like, I don't want to, you know, taking on transparency and how we learn and be mindful moment by moment is key to that. So anyway, I just wanted to say that sort of was the centerpiece of what I was trying to get forward, but I call it ordinary magic, that what we need is very ordinary. We know it, and it is magic, and as you know.
Yeah. So I just want to say one more quick thing. So I've been lucky in my life. I got DOD health care. I got VA health care. I'm a disabled vet. And I also, as an executive, go to the Mayo Clinic every year for physical. And I tell everybody, you know how they take blood at the Mayo Clinic? Anybody know? Any doctors? The same way they do at DOD and the VA. But when they greet you at the door, they say, oh, Mr. Falke, you must be starving. You fasted all night, sir. Let's get you up and get your blood taken. Let's go have a bowl of cereal. At the VA, they go, next! Hey, jerk off, what are you doing sleeping? Get off your BlackBerry, get in here and get your blood taken. And I've said to senior admirals, I have a former Army Surgeon General on my honorary board. If I had $1 at the DOD and VA, I'd spend 80 cents on it, treating them how to have bedside manner. You know, we know this, right? Harvard knows this. The propensity, even for malpractice suits, comes way down when customer care is good. And we don't treat people well. It's crazy. And you know, no disrespect to the medical community, but the psychological community is worse. I mean, it's worse.
And I mean, I agree. Anytime you're talking about trauma and for us racism, I better get cranky. Because if I am comfortable with all of that, then there's something wrong, right? I'm not attuning. I think that what we heard from our folks is that they already do this stuff, right? Because they have to, right? When you live in the communities that so many of our residents come to, the only thing they have is that type of survival mechanism, because they're in this common, they all share the same experiences, you know? And we've heard from several, especially the women in the community, who are like, I find out when people die, and I try to go console their families. We try to talk about it. You know, I do it all the time. And, you know, I have no time left for me, right? And I can't take care of myself. And I just got diagnosed with stage 4 lymphoma because I didn't have time to take care of myself. And then last night, my boyfriend got killed. That's a true story, right? About a woman in our coalition, about a woman in Gilmore Homes, right? About a woman who has seriously dedicated every minute that she has to helping other people heal from trauma, right? And she did it because nobody else would. And by nobody else, I mean us, right? I mean the people from outside the community. because we all stand around and say, who's going to do this? I don't have the money to do that. I can't. And meanwhile, they're not waiting for our money because they can't. They're not waiting for our services because they don't have time, right? They're not waiting for our attention because they're dying in the process, right? And so for us to recognize that they're doing this without us, right? And the best thing that we can do is try to facilitate the resources to support them. It's not, like you said, it's not recreating the wheel, because frankly, there's a council of elders in every community. They're not the elected elders, they're the natural ones, right? There's a council of folks that are going to take on solving problems and supporting folks. We have nothing to do with that. And when we try to get involved, we meddle it up. We muck it up, and then we try to figure out what went wrong with the community. Where if we would just find a way to give them what they need to do what they're already doing, and doing it in a way that gives them the tools that they really need, I think that's the purpose that we see in this grant opportunity, is no longer to impose what we want to do, but rather to create the space for us to be told what they need to do what they're already doing better. So I appreciate it, and I think that, yes, ma'am.
I just want to say one thing in honoring what you're saying. I hear a lot of them and us. And I think that's a place to begin. That what they experience is me. If somebody's hungry in Penn North, I'm hungry. If they're hungry in Saudi, Syria, I'm hungry. And I think we need to break into that paradigm too, that we are just one community. And I think it doesn't negate that there are different behaviors and experiences at all, but I think there's something for myself is important about that. Because it's, we're going to give them the money, and it's our money. It's their money. And it's just a way of letting us coach each other maybe on that, including me. How do I hold that? How am I them? And so therefore then, I want to have that experience for all of us to heal. Thank you.
I think in part of our first, we were told, you are not from here. You're not from here. You're not of and from the community, and you need to stop assuming that you know what we are, right? So I think the challenge is, and again, I'm not calling you out, this is me, right? Is that I have the privilege of saying, when you're hungry, I'm hungry. And the patronizing way that comes across to the folks that we've worked with has been really clear, right? Is that you're not us, and don't pretend you are, right? Is that you can be here with us, but you're not us, right? And to recognize that, I think that was one of the hardest things, because we were trying to do the best we could, and we had no idea that our intuitive step was the misstep that set us on this path, right? Our intuitive step, and I've struggled, right? Because I want to say when this happens, I feel for you, but the reality is I have no idea what it's like. I never grew up in public housing. I've never gone 3 days without eating, right? I've never worried if I was going to get shot when I walked out of my house, let alone if my boys were going to get shot, right? I never worried that, that I was going to get robbed. I never worried that my mom was going to get sexually assaulted, right? I never had to worry about all of those things. If I needed to go to the doctor, I could get an appointment. And I wouldn't have to sit there for 6 hours because everybody had to go to the same clinic. You know what I mean? Like, those are the things that I've never had to worry about. And many more, right? And for the kids that I worked with as a school counselor in West Baltimore, that was nothing. They used to get mad about gunshots because they had to go inside and they couldn't play outside anymore. Not because there were gunshots, right? Not because their friend down the street got shot. They couldn't play outside anymore, right? That's the normalization of the trauma that the kids in Baltimore, so many neighborhoods, it's not just West Baltimore, it's not just East Baltimore, it's Cherry Hill, it's Brooklyn. Frankly, it's Park Heights, and it's Northeast now, right? Like, it is everywhere. That our kids, no matter where they live, where they grow up, they live with this level of trauma that would break me in a week. You know what I mean? And so, I get where you're coming from, because I came from there too, and I totally respect it and admire it that you're there. But for us, we tried that, and we got checked hard in the gut and had to work really hard to come to this place where I can walk into West Baltimore again, because for a time, I'll tell you, I left that meeting crying, right? Because I felt, some kind of way, there's no better term, I just felt some kind of way. And it took me a long time to get to a point where, because I'm the one sitting in front of the room, right? No matter what happens, I'm still the white guy in front of the room of black folks trying to keep everybody together. Because I take hits from the community that this is going too slow. I take hits from the partners saying they want us to move too fast. I take hits from the health department saying, what are you going to go and say to that TIIH people? Right? Because this isn't stuff you put, there's a reason why my slides are so vague, right? Because this isn't the stuff that you put in writing. But it's the story, right? And it's the story that for us needs to be told to y'all as academics, and we scream it to funders. Because how many funders require community buy-in, let alone community leadership, right? And we met with a group of grassroots funders, and I didn't say much, because I had a panel of community residents who told us what happened. So, sorry, I'm long-winded.
That's good. That's good. We appreciate the depth of your feeling and experience about this. Brandon?
Definitely. No, I was just going to echo that, Andy. I appreciate you creating that picture of what trauma is and the experience in our communities and how they respond to these conversations, because it's very easy for us to pontificate came to mind about what's going on in these communities, but to be able to understand that experience, you have to live it, and if you don't live it, you're never really going to understand it. So thank you for bringing that perspective. But I think there's, in addition to approaching it at the community level, engaging and empower community members, we also have to come from that opposite end, what I think you all have touched on, which is looking at those upstream factors, looking at systematic issues, looking at the structures that are in place that are perpetuating the cycle that causes trauma in our communities. So it happens. It's happening to neighbors. It's happening to people that we see on the streets. But there's something that's causing it to continue to happen, because there are programs out there that work. There are models out there that work, and we know that. But it's not stopping it from happening. So in order to do that, we have to start to move upstream, look at policies, look at some of these practices. And I think that's where we come in, to start to figure out ways to, of course, empower community, but also address some of those systemic issues in place. So I won't jump on my Andy soapbox with that, but I wanted to make sure that we also reiterate that.
I just want to say that some of the work we've been doing tries to point out how we leverage current systems and structures to get at that through any door kind of piece. So if it's of interest, we can talk more about the very detail, like what are you going to do at a policy level. But I also want to just say the importance of narrative, because there's a lot of assumptions that go on. And, I grew up in Watts, basically, in LA. And if we don't tell our stories, we're never going to reach what you're talking about. And so the power of narrative and storytelling is important at all levels. And I think that's really the safe place, that we're talking about my experience. So you talking about your experience, everybody talking about what they're actually experiencing, we do start to see some of the common places where we do meet. And that, the data shows that it really isn't the event, it's what you did with it. And there are people, I've got a positive deviance group that have 4 more ACEs below poverty that are flourishing at a level that you don't get in Palo Alto with kids without ACEs. And so who are they and what is that? So we have so much to learn from each other, and we don't know. There's as much variation within or between. And that's sort of, really important to know, because it's possible. Like for every bad story, there's a good one. And so how do we use narrative and storytelling to start to break through this and really check that at every level, including, the white guy that gets to talk about your story too.
I think this is this has been an extraordinary discussion and set of talks. We could clearly go on till midnight, and we'd just be, touching the surface level There's a lot to talk about. There's a lot to do. It's an important problem, and I thank you all. And thank you all for your comments and listening, and look forward to seeing where this can all go. Thanks.